I'd like to thank LabRoots for the opportunity to give this presentation. So my name is Dr. Gary Procop. I'm the clinical virologist at Cleveland Clinic and a staff microbiologist. And the topic today is testing for SARS-CoV-2, and I wanted to share our experience. So I have no disclosures, and our objectives are as follows. I like to describe the optimal uses of the various types of SARS-CoV-2 tests. We'll touch a little bit, not a lot, on antigen antibody, and we'll touch a little deeper on different nucleic acid tests, discuss the molecular detection of SARS-CoV-2 during convalescence, a pretty important topic. We're going to discuss the impact of using a test with high specificity, something we all want, in the diagnostic versus screening setting. We're also going to review the benefits and limitations of alternate specimen types like saliva, that's become very popular, and alternate testing strategies like pooling, which has a lot of questions around it. So let's get started. I'm not going to spend a lot of time on things you already know. You know a good bit already about the SARS coronavirus. These viruses infect animals and humans, and of course, as we all know, unfortunately can jump species and become embedded in our species. So what do you do when you're asked to test for a virus that you've never met and leadership wants it done yesterday? Well, as you know, the government has a process called emergency use authorization. And how this unrolled in the United States is, at first, this was limited to testing for this virus was limited to public health facilities. It became readily apparent that the public health infrastructure was going to be bowled over by this, and they indeed were. And so the emergency use authorization was opened to others, and that includes diagnostic vendors to make and distribute tests, commercial reference laboratories, as well as academic institutions and other hospitals. Became immediately aware that the laboratory infrastructure, we've been saying for years, needs to be buoyed up, as well as the public health infrastructure. And those are areas for future discussions. So first of all, not all tests are created equal, and this has become apparent as we've rolled out these different assays. And so we decided at the clinic to bring up the CDC assay. What do I know about SARS-CoV-2, right? And so we really had the choice between that and the WHO assay. We chose the CDC assay, and immediately clinicians were asking, what's the sensitivity and specificity? And this was before there were any cases of SARS-CoV-2 in Ohio. I had to tell them I don't know. These clinical studies had really not been performed. So it's not an FDA submission trial, it's an emergency use release, right? And so what is in the FDA emergency use criteria? And there are a number of things, and you can find this on their website. And what I'd say is I think it's a good start. They have good things like in silico cross-reactivity analysis that you need to do in order to demonstrate that your primers and probes will not cross-react with other viruses or other microorganisms or human genetic targets, etc. They make you do things like determine a limit of detection, but then falls a little bit short. They don't say which limits of detection are acceptable or not acceptable. So I like to think that the FDA EUA is a great place to start. And EUAs are usually pretty limited in time. You think about how long did we use these for Ebola? Not very long. But we've been using these now for months and months. So I think there's opportunities for EUA plus after an assay has been in operation for quite a while. And those are, again, additional things to consider. So what we did was we ended up doing a 5-test comparison. And this has just been accepted for publication in American Journal of Clinical Pathology. So hopefully you can find it there very soon, if not when you're hearing this talk. And essentially what we did was we had brought up SARS-CoV-2, we brought up the TibMo Bio assay and the Roche Z480. brought up the Expert Express from Cepheid for our rapid assay, brought up another rapid assay, the Simplexa from Diasorin, and we were in the process of bringing up the ID Now. During that early assessment of the ID Now, we had a number of misses that made us do this study. What we did with this study was we actually said, we defined a specimen as truly containing the virus if any one of these tests were positive, and that positive could be corroborated by any other test. So you needed at least 2 tests to be positive to call that specimen positive. Single positive will be called false positive. And from this definition, you could determine true positive, true negative, false positive, false negative reactions, and determine your sensitivity and specificity. And during this time, we were most concerned about false negative rates because we were talking about which test could we use to put patients into the hospital. And we did not want to be putting people onto a COVID negative ward that the assay had missed. So you can see here, the top three assays had very high sensitivity and specificity. They really all had high specificity, but the 2 assays, Simplexa and ID Now, had lower sensitivities. And so we're going to come back and explain why a little bit later. But those are our initial findings, and we'll leave it there for now. So what was our experience on how to deal with a pandemic? And you can see Dr. Reddy's paper listed at the bottom, and she basically has written up with myself and other colleagues how we handled operationalizing COVID-19 testing at the clinic. And I have to say this has been a great experience. Our chief of medical operations, Dr. Bob Wiley, runs Incident Command, and has a tight ship, I'll say, and a lot of great lieutenants. And so this team would meet. We sometimes met twice daily early on. We would run tabletop exercises of what were worst case scenarios. All aspects of operations at the clinic were present. We would report out on current state. We'd have projects, tasks. We'd go and work on those, come back and report later on. So this very organized, systems-based practice approach was really key for us to address COVID-19 testing early on. A little bit more. What exactly is going on? How many tests are we doing? And this is where our informatics team was absolutely key. And so they were able to build dashboard after dashboard. I can't tell you how many dashboards we have right now. I've really lost track, as far as, outpatient, inpatient, stat testing, etc. But the point here is your informatics team is absolutely key, and they sure have been great partners. Test utilization, something I spent a lot of time in, and Dr. Reddy and Hendricks are running that show now here. But what we've really had to do is we had limited allocations of everything, just like I'm sure you did. And so we had to decide, how are we going to utilize the limited rapid tests that we had, the Cepheids, for example. How are we going to utilize the limited routine tests? I think we all saw from the beginning, if you just open the doors, you're going to be overwhelmed with testing. And so we really put in guardrails around these tests, again, with everyone at the table, and the conversation that if we just open the doors, you're not going to have tests for the patients that need it the most. So this team-based approach was really a great way to approach limited allocations. And again, there were home monitoring programs for those patients that were able to go home either after testing or after discharge, all through MyChart. And again, teamed up with medical informatics, making this absolutely key. So at the beginning, we were using a test-based strategy to bring healthcare workers back to work. And that proved to be pretty problematic because we couldn't get healthcare workers back. They had recovered from COVID-19, and we were requiring 2 negative tests to come back to work, and we couldn't get 2 negative tests. A test negative one day, positive the next, et cetera. And what we have learned, of course, and I'm sure you know this too, this COVID-19 has a long tail. And in that tail of convalescence, there are what is believed to be, and we believe to be, shedding of non-infectious viral fragments, viral particles that will be positive in the PCR test. And that was really hamstringing us to bring folks back to work. But we needed data to move to a non-test-based strategy. When we started to study this, you could see that the viral load became much lower as you move from left to right along the x-axis. The viral load becomes much lower as the days away from initial symptoms proceeds. So this is not surprising, but those are the folks that we were catching in this long tail of convalescence. So Dr. Shrestha, and that paper is, I believe it's going to be referenced in an upcoming slide. If not, it's in Clinical Infectious Diseases. Utilized the CT values, the crossing threshold values, to determine viral loads based on our lower limit of detection. And from this, you could see that, after about 14 days, you had such a substantial drop in the median viral load, over 32,000-fold, that we were convinced this was, in addition to other data that was in the literature, that this would be a fine time to bring people back to work. And so we used this data to move from a test-based to a non-test-based strategy. And I know, as you do, CT values have been used as a surrogate for really an official viral load or a quantitative viral load in this pandemic. So what are we detecting? I've already alluded to it, and you can see the paper from Nature Medicine demonstrating this long tail, as well as a repeat of Dr. Shrestha, and there is the reference. And there is good evidence that we are detecting non-infectious viral fragments. What is that evidence? There's a nice paper out of South Korea that demonstrates that these folks, when they go home, don't infect their family members. And as you know, if you have SARS-CoV-2 in an active disease state, your family members are at risk, at heightened risk. So that supports these folks are not infectious. And then also, this paper from Germany, as well as others, demonstrate that you can't culture the virus from these patients. So it's probably again, viral particles or fragments that are non-replicative. So let's go back to our 5-test comparison. And what we did was we looked at our patient populations, thanks to Dr. Harrington, our senior author on this one, who wanted to do this. And they reviewed the charts, and you can see that the folks that we were missing in the Diasorin and in the Abbott assay were folks that had lower viral loads. And both of these assays omit a nucleic acid extraction step, and that is what we believe is the reason. And this is pretty, there's a lot of supportive evidence, of course, and we've generated some of it in the molecular biology literature, that your sensitivity will increase, of course, if you have a high quality nucleic acid extract to start the amplification process. So we believe that that's what we were missing. Whether it's clinically relevant or not is another question, but that is an explanation for the limited sensitivity, the moderate sensitivity of those two assays. So I'll be relatively brief on antigen and antibody testing. Antigen testing, it's attractive because it's inexpensive, quick. The issue is it's less sensitive, but equally specific. And we have a long history in microbiology of knowing about antigen testing and studying antigen testing for infectious agents, from group A strep to years of studying influenza and respiratory syncytial virus antigen detection tests. And so in symptomatic patients If this test is positive, you have a high positive predictive value, you don't need to follow it up with a molecular test or with a confirmatory test, which usually is a molecular in this case. But if the test is negative, you will need to follow it up with a molecular test in a symptomatic person. A different issue occurs when you're looking at asymptomatic populations, and it's not limited just to antigen detection tests, but it's the production of more a higher percentage of false positives in this setting, and we're going to take a deep dive in that in just a little bit. Antibody tests, you saw the antibody test just flooded the market at the beginning. There's great evidence that antibody testing it should not be used for diagnosis. There are very limited instances where I've heard good arguments to use it. The immunologists that I know have readily convinced me these are not useful. There's both false positives due to cross-reactivity with other coronaviruses and other substances. There's no evidence, of course, that that positive tests makes a person immune. These are useful, of course, for public health surveillance, and we have CDC quotations here for the antigen test. It may be necessary to confirm a rapid antigen test with a nucleic acid test, especially if the result is inconsistent with the clinical context. So if they look sick and it's negative, you got to confirm it. If they look well and it's positive, you need to confirm it. Antibody tests, the Food and Drug Administration has not authorized antibody testing to diagnose COVID-19, and CDC does not currently recommend using antibody testing for diagnosis of any infection. So there you have it, antigen and antibody tests. And again, we'll take some deep dives on the issues of false positives and asymptomatics in just a few. Okay, so we started out with it's all about testing, and we've heard anybody who wants a test can have a test. This is not a good approach. This is what happens when you do that. It is really testing without a plan. Why would we ever do this? This is not a good approach. So grab a test, any test, serology, a less sensitive molecular, a more sensitive molecular. How about antigens? They're quick, cheap. I want those. This is not the appropriate approach either. Let's think this through. This is not our first rodeo in path and lab medicine. So let's go back to what's tried and true and implement those principles here. It's all about using the right test in the right patient care setting with an understanding of how the test performance characteristics and the prevalence of disease affect the positive and negative predictive value. Again, this is where we're going to deep dive. This is the way to go. So why these false positives? We saw this rash of false positives in Vermont, and we have a great quote from our governor, Ohio governor, and I have to say, Mike DeWine, has done a great job with our pandemic. Hats off to him. Ohio governor says his false positive is a wake-up call about newer types of coronavirus tests. So this is a non-medical person saying this. Come on, we need to employ what's tried and true. Okay, so what happened here? How do we get off the rails? Well, I told you we were asked to implement a diagnostic test for folks that we thought had SARS-CoV-2. And so a diagnostic test is typically used to confirm a specific diagnosis. Someone has signs and symptoms of a disease, and the test is performed. Yes, you're right. They do have group-based drought. It goes along with their red throat and fever, right? They do have SARS-CoV-2. It matches their signs and symptoms. But then these tests, the same tests that were made to be diagnostic tests, were migrated to a screening test, often in rule out diagnosis, right? We've got a healthy person coming in for surgery. I'm not saying these are bad things. I'm just saying we got to recognize the limitations, and I'll share those with you in a minute. And we have a healthy person coming in for surgery. We want to make sure they don't have a brewing an early SARS-CoV-2 infection because their outcome could be worse, literature on that. So we're going to use this test to rule it out. And so the issue with this is the issue of false positives that we'll discuss. And, you know, so for a highly sensitive screening test, you want to capture everybody, and then you want to differentiate true positives from false positives with a confirmatory test. Think about how we screen blood for donation. We'd rather have more false positives and throw those units away than give someone HIV or HCV, etc. So you get the idea. Broad net with screening tests. Critical background concepts we have to review. Pre and post-test probability. Pre-test probability is really another way of saying disease prevalence. So what is the likelihood that patient has a particular disease before the test is performed? I see a red throat, I see a kid with a fever, I see spots on their tongue, pretty high likelihood they have group A strep. This translates to SARS-CoV-2 too, right? Do they have the signs and symptoms? Post-test likelihood. What is the chance that they have that disease after the test is performed? And importantly, it's really the clinical reliability or accuracy of that one test for that one patient. And we'll see how that plays out in a few minutes. So, three interesting concepts you may not have thought about since school, but we're going to revisit them. Bayes' theorem, likelihood ratio, and Fagan's normogram. And these are going to come together in a perfect storm to demonstrate the importance of pre and post-test probability in test interpretation. So Bayes' theorem is really a probability of an event based on prior knowledge of conditions that relate to that event. What we talked about already, right? Pre-test probability. Does it look like the person has that illness? Then that's going to play into it. Then you can use sensitivity and specificity to calculate a thing called likelihood ratio. And we'll do that as a part of an exercise in just a couple minutes. And so a likelihood ratio greater than 1, probability increases, less than 1, probability decreases. And then interesting tool called Fagan's normogram, published all the way back in 1975, that's going to bring all these together. So our transplant surgeons wanted me to talk to them about false positive tests, and we're using our rapid test, our expert from Cepheid, and again, I'm reminding you of the sensitivity and specificity. And so here we are able to calculate for you a likelihood ratio. So we've got a high likelihood ratio, far above 1 of about 14, 13.94. And so pretty darn good test. Now, in our pre-surgical asymptomatic population, we were running a positivity rate of 0.5%. So about 1 in 200 patients that didn't look like they had disease were positive. So we're just going to use that in our calculation to demonstrate this principle. So let's break out Fagan's normogram, and I'll walk you through this. So we're going to concentrate on the red line first. And so on the left-hand side, I've got the red line starting at a 50% probability, 0.5. And so that is a patient that really looks like they probably have the disease, right? Now, it could be something else that's causing their cough and fever, but we're in the middle of a pandemic, pretty high likelihood. So let's run that line through our likelihood ratio of 14, and we come up with a post-test probability of, 90s, in the 90 percentile. I can't see it on this slide. The numbers are a little bit small. But we got a great post-test probability. They look like they have disease. We've got a test with good test performance characteristics, likelihood ratio of 14, and we come out with a positive predictive value, a post-test likelihood in the 90s. You could take that test to the bank. Now, same test, nothing has changed. Look at the black line. Let's look at our pre-surgical patients with a 0.5% pre-test likelihood, a 0.5% prevalence of positivity. Now run it through the same great test with a likelihood ratio of 14, and you are going to come up with a 7% post-test probability. So a very terrible post-test probability, all because the populations are different. It's actually amazing. How can the same test perform so differently in different populations? So absolutely key to understanding the interpretation of the results of tests in a diagnostic setting versus a screening setting. So let's go on, and I pull a chart for you out of the CLSI document GP49. And this just looks at the same thing, but what it's done is the lady that presented this to us put this in for the calculations of a generic test that's 95% sensitive, 95% specific, and look at what you have. Again, at the bottom of the screen on the left, if you take the prevalence of disease, that's 50%, just like in our example. In this situation, you've got a positive predictive value of 95%. You're only going to have 5 out of 100 tests that are false positives. You can take the positives to the bank. Drop this down to a 1% prevalence, i.e. an asymptomatic screening setting. Your positive predictive value becomes 16%. All the rest of those positives are false positives. So you can see that false positives become the bane of a screening program. So to sum up some of the things we've been talking about here before we move on is test performance characteristics, the sensitivity and specificity of an assay are only half of the equation. Prevalence of disease, the pretest probability, and the likelihood ratio of the test as determined by sensitivity and specificity determine the post-test probability that the test result is accurate for that patient. The use of the same high-performing test is different in a diagnostic versus a screening setting. And from some of the earlier data we demonstrated, these late CT values, these low viral loads, they could be one of two things. They could be very early in disease, or more often now, they're part of this long tail of convalescence that is a positive test that's clinically not meaningful. So let's shift gears a little bit and talk about saliva, talking about pooling, because we said we were going to do that, and some folks are interested in that. And so why would you ever consider saliva? Well, a few reasons. Less provider-patient interaction potentially, less need for PPE use. You're not having to take a specimen from a squirming patient. You don't have to make the patient squirm, as less patient discomfort. And so the question is saliva really superior to the nasopharyngeal swab as demonstrated by some of the Yale studies, and is a little bit counter to what we've always felt in clinical microbiology, with the nasopharyngeal swab being the diagnostic specimen of choice for respiratory viruses. So again, the Yale study got this started, a very well done study. I give them a lot of credit. They looked at first morning salivas in some patients with severe disease. They also looked at some other groups, but that's a group I'm concentrating on here. And as demonstrated in the images, they demonstrated a greater sensitivity with saliva compared with nasopharyngeal swabs, and a higher viral load. So this was also demonstrated by Kojima in their study, and they broke it down a little bit in a way that informed our study. And what they did was they looked at a supervised saliva collection, a nasopharyngeal swab arm, and an unsupervised saliva collection. When in the unsupervised, it's really, they were watching, but they weren't coaching. Supervised is really coached. And so the folks that were coached on how to do it right, they had the best sensitivity. Nasopharyngeal swab were next, and the unsupervised or uncoached was last with regards to sensitivity. And they believed that was because the patients failed to elicit a cough, which was part of the directions. Now, not everyone has found these. I've given you a couple of references here for folks that did not find saliva to be superior to nasopharyngeal swabs, and you can see the sensitivities there. and they found that viral loads, they and some other authors found that viral loads were lower. So again, it's an area where we're still working out the details, and we decided to do a study of our own. And we weren't just testing first morning patients. That didn't really fit. We were interested in symptomatic outpatients, and so we set it up for when they were scheduled. They'd give their saliva specimen. This, of course, was IRB approved. And we came up with this idea of enhanced saliva. So Kojima taught us the importance of the cough, and others have seen that too. We added a hard sniff or a snuff to pull in any upper respiratory secretions, and then elicit a cough, complete the specimen delivery with whatever saliva you could to give us 3 mLs. And this was done while they were waiting in line for the nasopharyngeal swab. So specimen collected first for saliva, and then afterwards for the nasopharyngeal swab. We looked at 224 patients. We excluded 8, and we described why, and we actually described those. This patient paper was just accepted in Journal of Clinical Microbiology, so you can look at all the details. But when we look at the 216 paired specimens that remain, 38 were positive by both methods, so saliva and nasopharyngeal swab, 100% positive predictive, positive percent agreement, and then 177 of 178 were dual negative. The one specimen that was nasopharyngeal swab negative, saliva positive, was indeed adjudicated to have SARS-CoV-2 present when we tested it on another platform. So then we looked at the mean crossing thresholds, or CTs, again as a surrogate for a viral load. And we did not find what Yale found. We found what some of the other researchers found. We found that the viral load was lower in saliva compared with nasopharyngeal swabs. So our conclusion from this was that saliva is an acceptable qualitative specimen for symptomatic patients. You get the same positive or negative result, but in our hands, there was a lower viral load in saliva. So I would worry a bit if I moved this into the asymptomatic group, that I missed some of the lower viral loads, the ones that may be clinically significant early in disease. I don't mind missing the late ones that are not clinically meaningful. So everyone in the pool or not, let's not get in this pool. These are the pools that are bad, loaded with people. But the pools we're talking about is, can you combine specimens and test them all, and if negative, report out the negative on everyone, and if positive, you're going to have to deconstruct that pool and find out who caused the positive. And we know there's a long history of pool testing in transfusion medicine and the like, blood donation. And so those papers inform some of these studies. When we started this study, it was a 95% correlation was needed between the neat or undilute specimen with the pools. That subsequently has been relaxed a little bit, and it can go down to at least 80%, with some caveats, may be appropriate with appropriate limitations added to the intended use that would mitigate the risk of false negatives, et cetera. So you get the idea. So a little bit of hedging there, but somewhere between 80 and 95% needs to be a match. We did this for a while at the clinic. We were able to do 2-to-1, and this was really because of the allocations of the rapid test, the Cepheid test. And we're trying to stretch them to go further. We were able to get 2-to-1 to work, not 3-to-1. And then we couldn't even get 2-to-1 to work at the regional hospitals using the same platform. So we are not pooling right now. But I was approached by the NBA, who partially funded who funded a study in conjunction with some donation of materials from Cepheid to look at a 10-to-1 dilution. And so this was an interesting study that is on my desk to get written up, but I'll share some of the data with you. We purposefully looked at specimens that were either in the mid-CT range, as defined here, or in the late CT range, and then diluted those 10-to-1 and retested them same day. And you can see that 10 of the 10 pools were detected that were in the mid-CT range. Only ones that were missed were we missed 3 in the late CT range. So again, is that clinically relevant or not? Probably is if it's early in disease. It probably is not. It is not if it's late in disease, convalescence. And so we had the opportunity to study the CT change with a 10-to-1 dilution, about 4 cycles. And again, we talked about what's the risk of missing. And this, all the data together, if you took all 20 and you got 17 out of 20, gives you an 85% correlation. So not terrible. But that was our experience with pooling. Again, we're not pooling right now, but you can see both advantages and disadvantages. So some pearls I'd like for you to take home is know your test performance characteristics. You've got to know how prevalence, the pretest probability, affects the post-test probability. Really don't use serology for diagnosis. It's not useful there. It's useful for public health surveillance. Saliva is a viable option for testing symptomatic patients. I did not do any asymptomatic, so I'm not commenting on that. Pooling will miss some individuals with low viral load. You have to do a risk-benefit assessment. If these were folks that were being admitted to the hospital, I would be worried about missing a low viral load. If these are folks that are going to go home with appropriate guardrails put around that test result, telling them to, still isolate themselves and use appropriate mitigation precautions, you probably could live with, missing a low viral load there. And again, information come back if or contact back if you are more ill. So in conclusion, tests are tools. Tools need to be used correctly. And you can see by the image on the top, we don't use hammers for screws and bolts, and we don't use wrenches for nails. So same story here. Tools you have to know how to use them. You got to know how to use your tests. You got to know how to use them correctly, which has to do with the prevalence of disease. And finally, a colleague of mine at University of North Carolina has said this many, many times, and I can't help but pirate it. We can't test our way out of this. Again, test our tools, use them in conjunction with all the mitigation strategies that we need to be doing, wearing a cloth mask, appropriate social distancing, appropriate hand hygiene, etc. And so that's how we're going to get out of this, and we will get out of this. So with that, I know you'll have the opportunity to submit some questions. I'm happy to respond to those, and I thank you for tuning in to this presentation, and Lab Roots for giving me the opportunity to give it. Thanks so much.